Well, good morning, everyone. Good afternoon, good evening, or whatever time it is when you're listening to this on a replay. This is Craig Maddox. I'm the CTO of Moberg Analytics. I'm joined by Dick Moberg, our CEO and founder, and Ethan Moyer, our VP of R&D. And I'd like to welcome you to this is our, I believe, 15th webinar. And as always, just to go over a few things at the beginning here, really the goal of these webinars is that we realize that treating brain injury is a gigantic mission, and our mission as a company is to help you along that mission. And these webinars are an extension of that goal, a tool that we use to try to further that mission. We do things like this where we set up tutorials, we provide cases and examples. We, in some instances, are able to provide data and tools for you to use as an example. We have online tools, Jupyter environments that can be used to do data exploration and dip your toe in the world of machine learning. We also provide in-kind starter grants of cloud time and tools and consulting to help get your project off the ground. So if you're interested, if you see these amazing talks and are inspired and think, I have some data and I have an interesting question that I want to ask, please reach out to us because we like to help people get started in small ways, because small ways can lead to big things. Also, please provide us feedback. If these are for improvements, if you know of people doing cool work in this space, please reach out and suggest topics or speakers. Or if you've got something you want to share, please volunteer to speak. We're always building our list of the next speaker. We've got a few planned out for the next 4 or 5 months, but we would love to get you on the docket because this is every time someone comes on and does a webinar for us, we're just amazed and blown away, and it's really cool. It's really cool to see all the amazing work done by you and your peers. We've got a nice library built up of previous webinars. Like I said, I think this is number 15. So you can please go out and view the replays if you haven't seen them. There's some great stuff out there. The easiest way to reach them is via our website at that link, or if you go up to our main website, click on resources, you'll see a link for those there. Also, if you want access to some of these tools, please reach out to me or info@moberganalytics.com, and we can get you set up with access to this environment where we have some of this data and whatever assets we're able to publish on there. So we can't publish everything because of some stuff is still up for publication, but we are constantly building examples and adding data to that environment. So it's a great way for you to check out some of the stuff that's available. Also, please use the Q&A feature on your Zoom. Everyone's real familiar with that by now. Today's speaker, we are delighted to have Dr. Morteza Zabihi. He is a biomedical engineer who specializes in physiological signal processing, specifically with AI and ML. He's the associate director and lead scientist at the Massachusetts General Hospital NeuroAI Center under the direction of Dr. Eric Rosenthal. He's also a clinical instructor at the Harvard Medical School. He earned his Ph.D. with distinction in Finland and then joined MGH as a postdoc where he's been since. We met Morteza and I've worked with him for quite a while now through our collaboration with Dr. Rosenthal at MGH Harvard. His research focuses primarily on equitable AI and ML in brain injury prognosis. He's done work in coma recovery prediction, ICP analysis, seizure detection, cardiac anomaly, and early sepsis prediction. Today, he's going to discuss EEG signal processing and machine learning in coma recovery prediction. He'll give us an overview of EEG signal processing and then discuss two recent approaches for EEG analysis in this area. Obviously, when you're talking about predicting recovery and predicting outcomes, there are ethical implications of these techniques. So he's also done a lot of work in trustworthy AI, and so he'll end the discussion by discussing some of the challenges and strategies for developing AI. I remember Dr. Zabihi's talk at the NCS last year was fascinating in this area. It's something that we're very interested in. So with that, I will shut up and turn the floor over to Dr. Zabihi and let him start the presentation.
Thank you so much for the introduction. Unfortunately, due to some technical issue, it seems that I'm not able to share my video, but I'm gonna start to share my screen. Hopefully it works. Um, could you please confirm if you can see my screen?
We can.
Okay, great. Um, so before diving into the main content, I would love to mention that some of the images and the content I use here in my presentation are from other papers and third-party sources that just being used for educational and informational purposes. And I have no financial disclosure and conflict of interest. So um, I think as a motivation, we really need to know why we need a trustworthy prognostic tools. And one of the main reason, the first reason is because of the stakeholder frustration. In several studies, it has been shown that a clear expression of the prognostic estimates and uncertainties kind of missing in the family meetings between the clinicians and patient surrogates, and lack of this kind of clear expression of the prognosis kind of make the surrogates do not understand what is the status of the patients and how it's going to progress. The other reason is that most of the time surrogates prefer a numerical estimate. They would like to give them a single number to understand how it's going to be and what's going to be the status of their loved ones. However, the clinicians usually avoid providing this kind of numerical data. And one of the reasons is that most of the time these tools are not have been validated on a huge amount data set, different cohorts, and therefore they are trying to avoid giving kind of misinformation to the surrogates and the patients during the family meetings. The other reason is that it has been shown that for the people in the neurocritical care area, like for example the traumatic brain injury patients, around 70% of the deaths in the ICU for these patients is from the withdrawal of life-sustaining therapy, WLSD. And in US alone, for the cardiac arrest patients, 2,300 patients die from the early WLSD. And the main question, the critical question is that all these patients that they have this WLSD, are going to have the poor outcome, or if we give them a chance, they have the potential to get a kind of recovery and come out of coma. So there are many tools to try to answer this. One of the interesting project and the studies has been conducted by Dr. Edlow and his team in Mass General Hospital that they try to utilize the fMRI. So basically they play some asking the patients during the MRI scan and ask them to imagine performing a specific task. And interestingly, around 15 to 20% of those patients exhibit some kind of signs of consciousness. And the most interesting thing is that among those patients that show these signs of consciousness, there were some patients that they appeared totally unresponsive during this comprehensive consciousness assessment by a nurse that usually been done by the bed. And so this basically shows that there are some patients that they have this kind of covert consciousness, and we need to do more comprehensive study to understand how we can do the prediction and understand the status of the patients. But the problem, for example, with this type of approach and the challenges is that there are some kind of logistic constraints, safety concerns, like moving the patient from the ICU room to the place that they can take the MRI, and it can put them in danger. And of course, in terms of the financial, it puts a lot of pressure in terms of the money that needs and the cost, and also they cannot be done in a continuous way. So we cannot take the MRI several times per day for the patient to understand their status and kind of updating their status. So this is where the resting state EEG is a good tool that can fill these gaps, and we can utilize it. So this is why there's several groups and numerous works and study has been conducted utilizing the resting state EEG to do for prognosis of the uh, people with the coma. But the problem with the EEG is that the EEG is kind of complex, and uh, even the human experts, they have some disagreement between different annotators. And as you can see, for example, in this image, this shows a pattern of lateralized rhythmic delta activity in one patient, and the doctors or the expert needs to look at different channels of the data and trying to understand what is the morphology of the signal, what are the patterns, what are the frequency, and this can be getting harder and harder as we have more data. Sometimes we have hours, days, and months of EEG recording. So it's easily some part of the important pattern could be overlooked. And this is actually a motivation of using the signal processing and machine learning. So utilizing these tools can offer rapid analysis. Sometimes they show that they have a potential for better detection, reduce the amount of error, specifically if you're dealing with the long-term monitoring. And in many study, it has been shown that they are kind of successful and they provide a promising performance when they are doing the predicting long-term outcomes when they utilizing the EEG. So there are different ways to categorize these type of approaches. I'm trying to categorize them in the most conventional way, that what do we mean by EEG signal processing? So by EEG signal processing, you can look at the signal at different domain, at different aspects, like from the time domain, frequency domain, time frequency domain, and nonlinear dynamics. So for example, for the frequency domain, most of the time, we are using a tool named Fourier transform, which basically decompose the signal into its basic frequency components. And you can think the signal as a kind of mixed fruit smoothie, and the Fourier transform is would be able to give you what kind of fruit has been used in that juice and what is the flavor intensity of those fruits in your juice. So this provides a lot of important feature and characteristics of the signals. So here is just a very quick examples of a signal that I generated with a combination of three sinusoidal signals with three different frequency, with a sampling with a frequency of 50 hertz, 120 hertz, and 300 hertz. And then I add just a random noise to it. And the signal that you see here is the result of this combination. When I transform this signal into the Fourier domain and into the frequency domain, you can clearly see that I can see three peaks that are associated with those frequency component of the signal, which are 50 hertz, 120 hertz, and 300 hertz, exactly the same frequency that the signal has been generated by those sinusoidal. So this basically give us a kind of very interesting insight about the signal and its frequency component, and it has been shown that we can using this kind of tool, we can extract a lot of interesting characteristics from the EEG signals. So one of those tools and one of these tools that has been used specifically for a study of the disorders of consciousness is this ABCD classification, which basically look at the power spectrogram and trying to find out where the signal we have a peak. And based on that, they're going to classify into different classes of A, B, C, and D type. And those classes are kind of associated with the state of the consciousness, and they can also show that they have some predictive value for coma recovery. So for example, in figure A, you can see that the patient has some peaks in frequency between 1 to 4 hertz, and the GCS of this patient is 3. And the GCS here means Glasgow Coma Scale. It's just a numerical score that they give to the patients to measure the level of consciousness. 3 is the lowest level of consciousness, and 15 is the highest. Figure B shows the peak of the patients in this frequency range, and therefore is classified B, and so on. And has been shown that based on where we do have the peaks, at which frequency band, it can give us some clue what is the status of the consciousness of the patients, and of course we can use it as a predictive, give us some predictive value. The other interesting and established tool is a spectrogram that basically looking at the time and frequency at the same time. So here in this figure, you can see that the vertical axis shows the frequency and the horizontal one shows the time, and the color or intensity of the color shows the power of the signal. So you would have the possibility to look at the data and see at which time and at which frequency you have the most power or like more information in your signal. And it has been shown that it's a very critical tool for both clinicians and researchers to understand the signal and do some diagnosis and prognosis based on the spectrogram. Another tool that provides the same type of information is the wavelet, which basically doing the same type of approaches that decompose the signal into different frequency bands. But the difference between the wavelets and a spectrogram is that, so for example, imagine that you are watching a kind of a sheet music scrolling past while you're listening to a song. While you're using the spectrogram, you would see one page of that sheet music at a time. But while you're using wavelet analysis, you have the possibility to zoom in and zoom out based on the complexity of the song that you're listening to. And this is what makes it more sophisticated than the spectrogram. So you have this flexibility to zoom in when you have more frequency information, you have a higher frequency, and you can zoom out when you have a lower frequency or fluctuation in your data. The other tool is nonlinear dynamics, and basically coming from the chaos theory. And one of the interesting examples is this figure. So this figure shows the white noise that basically there is no correlation between any points of this data. We just randomly assign some points and generate this signal. The other figure, which this one shows the logistic map signal, which is a completely deterministic signal and generated by this very simple formula, which means that every point at a time is generated based on this formula of the previous data. And as you can see, this is how the signal looks like. If we plot the power spectrum and look at the frequency domain of these two signals, they kind of look like the same. We have a kind of a flat spectrum in the frequency domain. And most of the time, this means noise because there is no a specific frequency, and the frequency at all the time are kind of the same. And this is one of the interpretation of the noise. However, you see that these two signals are generated from two totally different nature. One is completely noise, and the other one is coming from a deterministic signal. But there are tools that the nonlinear dynamics offer to be able to differentiate these two, and that is like phase space reconstruction that basically study the dynamics of the system without having those underlying equations. So as you can see here, the representation of the signal of the white noise and logistic map signal is totally different in that space. So the idea is that we have all these tools, and each of these tools have their own advantages, and they kind of shed light at different aspects of the EEG signal. So one of the examples that we utilize all these tools, a signal processing tool, was the work that we developed at the framework developed for predicting functional recovery after the post-cardiac arrest, coma. So we're trying to utilize the first 72 hours of the EEG data to predict what's going to be the coma recovery in the 6 months. And this shows the result that we achieved the sensitivity of 79.2%, while our specificity was equal or bigger than 95%. And this approach achieved the first place at Physiological Challenge 2023. So what we have done after we do the pre-processing, trying to remove the noise, bypass the signal, we windows the signal into 3 minutes window, and then we extract a comprehensive set of 362 features from each of those 3 minutes window of the EEG data. So those features include a lot of information from time domain, frequency domain, time frequency domain, as we discussed. So here are some of the example of those features, like yours activity, mobility, complexity, which are basically showing and characterizing some of the statistical features of the signals. Then we extract some complexity at different frequency band, spectral power, power ratio. We are looking at the spectrogram and we extract some features from that domain as well. And for example, one of the interesting features that we have extracted was the sleep spindles, which basically is a train of this distinct waves between the around frequency of 11 to 16 hertz, and they usually last longer than half a second. In the previous studies, it has been shown that the number of the spindles is associated with this with the consciousness status of the patients. Like in this figure, in this study, shows that the unresponsive wakefulness syndrome for the patient that they have a very limited or they are unresponsive, the number of the spindles is significantly lower than the patients who were minimally conscious states. And this shows the control group. So basically, this was actually, interestingly, was one of the identified as one of the important features in our framework. The other type of feature that we have extracted, we look at the synchrony of different channels that recorded the EEG signal from different part of the brain. And there are so many measures and metrics to quantify this synchrony, like the phase lock index, coherence, the changes, the difference between the activity of the frontal and occipital challenge, and so on. So this is also part of the features that we have extracted from our EEG data from every 3 minutes window. Once we have extracted all those features, we need to somehow let the model know that which window is coming first. We need to let the model know what is the order of these windows. So for example, if this window occur at the first 24 hours, or this happens in the second day or in the third day, that's kind of important information that we need to somehow encode that in our framework. So we utilize this sinusoidal positional encoding to let the model know, knows that which window coming after which window. And this is like very important things we need to consider when we're building the model, specifically if we are dealing with the time series data. So we utilize this approach, which I believe, I think has been used in the famous paper, Attention is All You Need. But in that paper, they were using this approach with the deep learning models, but here we utilize it with non-deep learning approaches. So we encode the order of the windows in the feature space. And once we've done that, before fitting the data into the models, and in order to avoid overfitting, we partition the data into different non-overlapping partition, and we train our models on every partition except one, and we repeat that until every partition is once being excluded. And the reason behind that is that we want that our models to be completely robust and not going to be overfitted on a specific subgroup of patients. But the main question is that how we should split the data. So one way is to do like the cross-validation committee, that you basically randomly split your data. But the other solution is that you can split the data based on your confounder space. So here is just a hypothetical example of how we done that. So imagine that you have age as your confounder space. Here, for example, we have three group of age subgroup, like the young, children, and elderly. And this is the way that we train our different models. So the first model is trained on the young and children patients, and then we test it on the elderly ones. The second model is being trained this time on the elderly and children patients and tested on the young patients. And the last model is being trained on the young and elderly patient and being tested on the children patients. What is the reason that we are doing this? So the first advantage of doing this is basically it can give us, and it can identify the invariant features. So what features that they are consistently being selected as the top features in this framework, and no matter where you train your model and where you test your model, this is always going to be selected. This is actually means, in simple word, means that these features are not sensitive to those subgroups, and they are always being selected. And this could give us a lot of clue about an understanding and identifying some interesting biomarkers of the EEG, which are not sensitive, for example, to the specific confounder. In this hypothetical example is age. The other advantage of that is that once we train all these models, we can use them as a panel of experts and have a kind of ensemble learning, which means that each model is gonna generate a prediction probability, and then at the end, we're gonna fuse those prediction probability to generate the final prediction probability. And it has been shown that these type of approaches usually not only give us a better performance, but also give us a more robust performance, which means that the chance of overfitting is reduced significantly. This is the second work that we have done utilizing these signal processing approaches. So this work have some significant difference with the cardiac arrest work. One of the significant ones is that the previous work we are doing one-time prediction. So we look at the first 72 hours of the data and predict what's going to happen in the long term, whether it's a good outcome or it's a poor outcome. But here we are doing that in a continuous way and in a prediction horizon between 24 to 72 hours. So which means that we look at the last 14 hours of the EEG data, and we're going to predict the next 24 hours to 72 hours, and we're going to slide that window. We move forward 5 minutes through the time, and we're going to again do the prediction and updating our prediction of the next 24 hours. So this is kind of an interesting tool because it can provide an insight how the prediction probability progress through the time, and can give some insight to the clinicians and the surrogates. In that work also, we have extracted the comprehensive set of features from each of those rolling window, and we're trying to use an ensemble model to predict the outcome. The other difference with the previous work and majority of the works in this domain is that instead of having a binary outcome of the good outcome and bad outcome, we utilize different breaking points of the disorders of consciousness level, and we define this as a three-class classification problem to give us a more granular understanding prediction probability for different consciousness states of the patients. Another interesting things that we saw when we were looking at this 24 to 72 hours prediction horizon is that how dynamic the DOC level or the disorders of consciousness of the patients can be. So in the first row, what you're looking at is showing in the first day of the admission, and how the DOC levels, this coma, vegetative states, minimally conscious state with and without language, and this post-injury confusional states, how they transition between one state to the other state. So this second graph here, figure shows in the second day how this dynamic is happening, and in the third day how this is happening. And different rows actually shows different prediction horizons. The second row shows the 48 hours prediction horizon, and in the third row shows the 72 hours prediction horizon. So I think the takeaway from this slide is that even in a short term prediction, the amount of the transition between different states of consciousness is significant. Another things that we saw when we were conducting that study, we understood that some of the features having at some patients, they're having a high correlation with the Glasgow Coma scale. So for example, this figure shows the value of I think this is a Petrosian fractal dimension as a features of the complexity of the signal. And this feature shows one of the relative power spectrum frequency-based features. The value of the features elevated and a predictive of what's going to be happening for the GCS in the next 24 hours. And this is an interesting way of showing that how the value of the feature changes even before the GCS change. So it kind of shows that there are some things, some patterns happen, some patterns change in the EEG data at the current time that we can use it, and they have predictive value to do the prediction in the future. So here, this shows the approach that we use, that we name it confound isolating cross-validation, which basically we split our distribution into three parts based on the diagnosis, time of admission, and age. So for example, if the patient has a TBI, traumatic brain injury, subarachnoid hemorrhage, and the time from the admission that the EEG is being recorded, if it is less than 4 days or it is more than 4 days, and the age of the patients. So as you can see, for example, in this first figure, when we use all the data from all these subgroup of patients, and we train those a model and test it on this specific subgroup of patients, which are patients that they are less than 45 years old, the age is recorded more than 4 days after the ICU admission, and they have a traumatic brain injury. So it shows that our model kind of do not give us a promising result. So first of all, this information can be used to understand where our model fail and which type of subgroup of patients that the model kind of marginalize. And the other also, it can help us to not only improve our model, build a model, but also maybe indicate that there are some pattern in the EEG that is different in this specific subgroup of patients. And we need to look further into those patients. So I think the takeaway from this slide is that just reporting a average performance of the predicting is not definitely enough, and we need to do different type of cross-validation. So one of the reason that this is different from subgroup analysis is that it's not going to affect the sample size significantly, and you basically use all the data that you have available for training, and you're going to exclude only a specific part of the data for testing at each time. So the idea of having a model, an AI ML model, to be trustworthy is that not only having a good performance, we need to know if there is any bias in the data, if the model is going to marginalize a specific part of the patients or a specific distribution of the patients. If the model is robust, if the model is being used in hospital A and give us a good result, does it mean that the model also give us a good result in hospital B or no? The performance of the signal, and also if this is a fair or not. So there's so many things that need to be considered when we are building a model. So at the end of the day, we can say we trust the model so we can use it in practice. So in most of the time when we are talking about extracting the features and building a model, either we are using a classical machine learning where we have some expert-based knowledge about the problem and we're extracting some information, like the two examples that we have developed, that we're extracting some specific feature from the complexity, some connectivity measures, and so on. Once we extract those features, we're going to feed those features to the model, and then we're going to do the prediction if this is going to be a poor or good outcome. But in the more novel way, that is deep learning, that the whole process is going to be done basically automatically and data driven, and it's going to learn which features are associated with the poor outcome. So it has many interesting features and advantages. But the problem is that sometimes when we are using the deep learning approaches, you're not looking at the very robust features. So what do I mean by that? So for example, when we are dealing with expert-based features, we are looking, for example, at the sleep spindles, we connectivity measures, a spectral power, we know what we are measuring. But when we are dealing with the deep learning, we do not necessarily know what are those features are measuring. We just know that in average, these are correlated with the labels, which in this case is the coma recovery of having a good or bad. So this is why most of the time, not always, but most of the time when we are dealing and working with the expert-based features, they're going to give us robust features. But when we're using deep learning, they're not necessarily robust features, and they can be not robust. So one of the reasons is that specifically when we are using the very deep model is that they're very sensitive to noise. And this is what they name it adversarial attack. So it means that if you add a very small amount of noise to your input data or into your feature space, the model could misclassify the model, although the model should be kind of immune to those noise because it shouldn't be sensitive to those noise. Those noise doesn't change anything, but it would be able to change the prediction outcome of these type of models. So one of the example of this is in this work that shows this is the original example. They add a very small, tiny amount of noise to the EEG data that cannot be seen by the naked eyes, and then you can see the result after adding the noise. So basically, they are almost identical, the original and the one that with adding the noise. But if we fed this to the model gonna classify this as class A and classify this as class B. And therefore, there are so many methods to make the model robust to such kind of noises. Either they are adding the noise manually into the input data, or they are doing that during the training in an automatic way and in data-driven to make the model robust to such noises. The other type of robustness is out of distribution robustness that we mentioned briefly, that if I made a model in hospital A, does it going to work on hospital B or no? When we say that the model is robust, it means that if the model works in hospital A, the performance should not drop significantly when we are deploying that in hospital B. So there's so many reasons that this could make this out of distribution robustness in danger, like the covariate shift, concept drift, temporal shift, which basically, for example, if you build the model 10 years ago, you'll not be able to use it right now. You need to update the model. If, for example, you train it on a different, so your models or your annotations are based on different diagnostic criteria or medical guidelines, and you want to use it on different hospital with different diagnostic criteria and guidelines, you need to basically update your models. Or if your model is being trained, for example, in hospital A, where majority of the patients are male, and you're going to test it on a patient on a model on a hospital that majority of the patients are female, you need to make sure that the model is not the performance is not going to drop significantly. So as you have seen, there are so many steps to make sure that when we are dealing with the AI and ML, that we need to take care of to make sure that we have a robust model. For example, if you have an unbalanced classes, majority of the data belongs to class good outcome and minority belongs to class bad outcome. So you need to make sure that the model would be able to balance between those. Sometimes you need to do the resampling. Sometimes you need to work and tune and change your loss function. And sometimes you don't need to do anything. So you need to, for example, to do some kind of calibration. So there are, based on different tasks that you have in hand, different approaches and different techniques need to be used. When we are partitioning the data to evaluate our model, like training and test set, how we can avoid data leakage. So our model, when it's trying to do the training, do not see any information from the test data. And so do not generate overfeeded result and evaluation result. So when we should use the ensemble learning, what type of performance metrics that we need to use that are kind of tailored to that specific problem and give us a true evaluation of the model. So using only one or two like metrics doesn't really show anything about the prediction. And we need to utilize a different type of metrics that being used. If we do not have enough data, what type of approaches we need to take to make sure our model trained with the sufficient data, how we can generate synthetic data, how we can generate counterfactual examples, and so on. So I think the takeaway from this slide is that writing few lines of code to train and test the model is maybe give you the good average performance, but most probably it is not going to be a robust or trustworthy model. So I think we think that there are few future direction that we can work on it to fill some of these gaps and having better and more accurate models. So the first one is the bias in the coma science. Sometimes the bias is evident and we know those. And sometimes they are hidden in the data and we need to utilize different algorithms to first identify them and then make our model robust to those changes. The second one is task constraint models. Majority of the models being trained and developed are for a specific task. And if we want to build a model that for different problems, or we want to use those models for different problems, we cannot use those. So it would be great to have a pre-trained kind of foundational EEG models to be able to utilize it whenever we do not have enough data to train a big models or sophisticated models. And there's so many foundational model for different field is available, but there are very few available for the EEG modality. But the problem with majority of those foundational, the existing ones, is that they are built without considering the nature of the waveforms and the time series of the EEG data. So for example, they're usually inspired by the machine vision or natural language processing, but the EEG data and the waveforms require the specific kind of consideration. We need to consider different information and focusing, for example, on the temporal changes. So it needs a specific and a special foundational model for the EEG data that there is a lack in the field right now. The other thing is that once we build a model, we really don't know what is the actual evaluation of that, and we need to there should be some way to standardize the validation. For example, in natural language processing in the field, there's so many data set that people would be able to utilize and benchmark. But in the EEG signal processing, specifically in the neurocritical care, I think there is a lack, and we need to kind of fill this gap by building a framework that people would be able to submit their code and their model, and we would be able to fairly evaluate the model against a comprehensive and large data set. And the last one is that even when we build this model, what is the human factor aspects of that? So for example, even if I have a good model, does the clinicians do they really want to use that? Do they trust that? The family patients, do they want to like use that model? What aspects of AI trustworthiness is more important for them? So for example, when I report the outcome of the model to the family of the patients, is it important for them to understand which feature has the most higher importance score, or it is important for them to understand that what is the uncertainty of this prediction, or what's going to be the prediction of the patient with the same status as their loved ones, and how the model perform on those. Do the clinicians really need to understand what is the exact, for example, architecture and topology of the deep learning model that's been utilized in my model, or they would love to understand what cohort has been used to build this model, how much the data sets that we used for training is gonna like cover different patients with different status. So I think this is one of the other aspects that even if we have a model, we need to understand what aspects and what factors of interpretability and explainability of the model really is going to help us so that the clinicians and the main stakeholders in general going to trust our models. And yeah, thank you for your attention.
Thank you very much, Dr. Zabihi. That's a fascinating talk, and it's really interesting when we get into the explainability. You actually hit. I was about to ask a question, and you kind of hit it on that last topic. how we address, there's such a lack of understanding on how models work with, especially with deep learning. And we're starting, so when we start to apply them and in delivering news to families and patients that, that their loved one is likely to have a poor outcome, um, how will we solve that? How will we solve that lack of explainability? There's part of me that thinks, well, it's just going to come naturally, and it will always come slower in medicine than it does in other areas. But we're just going to get used to these complex models making decisions like, yeah, it's driving my car and flying my plane and managing my portfolio. So maybe at some point we will get used to it. But it's interesting. Is there actually work going on about how to how to do that, how to explain that, how to do the proper training of the people delivering the news, and in such a way that it's accepted and understood to the level it can, especially with the deep learning, which to me, I mean, it's just I have no idea how they work.
Yeah, I think so. One of the reason that our lab is actively working on this aspect, and we're trying to in the processing, and actually we already pilot a dashboard for trustworthy AI, so we can show it to clinicians and family patients, and like gather the feedback and understand which aspects really matters for them. This is what we are working on. There are also other studies that have been working on that, but they're not very, first of all, specific to the to this domain. I mean, critical care. For example, you looking at different aspects of the AI and tools like using usability scores and acceptance score, looking at different aspects. But I believe it takes totally different, we need totally different studies and surveys when we are dealing with the health and specifically with the patients in the neurocritical care area. So, and this is one of the reasons that we started to work on this area, and we already pilot a kind of a dashboard for AI trustworthiness, and we are actively working on that area.
Well, that's good to hear. I think it's so important to get that aspect of it. If anybody else, please raise your hand or put a question in the Q&A. We're probably small enough to where we can just unmute people and let you speak if you want. But please put any questions in the Q&A, and we'll jump on them. I'd also be, maybe Ethan has already talked to you about this, but we would definitely be interested in working, like when you talk about building systems to do benchmarking, that's an area I think we could work together on as well. And deploying the dashboards is a really cool idea too, because where our own software stuff has lots of dashboards in it. So as we start to deploy models, seeing the work you guys are doing in the explainability would really be cool, because I think that would be helpful. Although our systems are designed to mostly be used clinically, I think that the explainability, I mean, that's the first step, right? If the clinician has to understand it first before they try to explain it to a patient or a family.
Yeah, that would be very interesting.
Yeah, that'd be cool.
On the implementation side, just to bounce off Greg, there is, I mean, you're likely interfacing with data that's already, in these really nice EDF files, but when you actually want to implement in a hospital, you run into, interfacing with Cadwell, interfacing with Natus, interfacing with these systems, which makes it, more difficult to implement because, the EEG montaging isn't the same. The data stored in a variety of data lakes and databases. Have you encountered that as a barrier in thinking about how you're going to implement this through these dashboards you're building?
For the dashboard, no, but for the work that we have done for the cardiac arrest that I just described in this presentation, the data said, I think they were collected that data from 7 different hospitals from different countries. And we have that issue that you're mentioning, that there's so many missing channels, recording with different recording systems, and there's so many variability between the data that we have in our hand. So I think one of the important things that we need to also consider when we are building the model, how to make the model robust to these kind of fluctuations. And this is one of the things that we considered and when we were developing our framework for that cardiac arrest prediction work. But I think that would be also interesting to put that in our AI trustworthy dashboard as well, to show that how the model is being trained and how it accounts for different variability with different devices and different clinical environments. That's an interesting point.
Very cool. Well, if there are no other comments or questions, we will go ahead and end the webinar now with just one more big thank you again for you, Dr. Zabihi, for coming and sharing this amazing work with us.
Yeah, absolutely. Thank you for
ever since the presentation at NCS last year, I was like really, really, really cool work. So
I appreciate it.
thank you so much.
Thank you.